Hello, welcome back to this channel. My name is Dr. Saif. This is the third module of Basics of Mechanical Ventilation. Today we are going to learn how to start mechanical ventilation, what parameters to set and monitor, and based on few variables how we can change the settings. We will also learn how to carefully set the alarm settings on monitor. After you have completed the pre-use check and checked all the connections also, now this is the time to initiate the mechanical ventilation on eligible patient. This process involves three sequential steps, starting from patient preparation, setting up the ventilator and actually starting the ventilator. So these are the three steps, and then you have to monitor also the patient who is on mechanical ventilator. Then you have to also see the alarm. All these things you have to do, in a sequential order. First step is the patient preparation, which requires the preparation of a sedative agent, as during initial mechanical ventilation you would like to monitor the lung mechanics of patient, and you do not need any kind of patient discomfort or patient ventilator asynchrony. So a good sedative of choice depending upon the patient characteristics and his organ status should be prepared, loaded in a syringe and kept ready on a syringe pump to be attached to the patient IV access. Then attach the monitor on patient and keep vitals checking like ECG, heart rate, blood pressure, SpO2, etc. Note the baseline value. For blood pressure, I would suggest to start NIBP, that is non-invasive blood pressure monitoring, cycle at every 2 to 3 minutes till you have started the patient on mechanical ventilation. Then you may keep the NIBP cycling set at every 10 to 15 minutes or so. This will help you to detect the post-intubation hypotension early. Now look at the patient's baseline investigation and see the ABG. This will help you to set the ventilator settings. For example, if ABG shows metabolic acidosis and hyperkalemia, it will be imperative to set the ventilator in a hyperventilatory mode during initial few hours till you manage hypokalemia. To keep injection soda bicarb ready and to administer anti-hyperkalemic agents, and also to prepare yourself for expected ventricular tachyarrhythmia and all. So more you will be prepared for the worst, better will be your patient management. Baseline investigation will also guide you to select the sedative agents for intubation and subsequently for mechanical ventilation. For example, if patient has deranged liver function test, you would avoid propofol or even thiopentone and would like to use better agents such as etomitate with fentanyl or atracurium or cisatracurium for sedation and paralysis respectively. Intubate the trachea using a proper checklist of intubation as advised by standard guidelines such as AIDAA, that is All India Difficult Airway Association 2016 guidelines, which are unique guidelines, first of its kind for tracheal intubation in ICU. After tracheal intubation is done, connect the tube with ambu bag and push in 4 to 5 puffs of air while auscultating the chest. This will give you the tactile assessment of lung mechanics in your hands, whether it is difficult or hard to ventilate or whether it is very easy to ventilate. You will find out. Bronchospasm and poor compliant lungs will be difficult to ventilate, obviously. After patient preparation, you need to set the ventilator, right? While you are manually ventilating the lungs using ambu bag, or even you may use the Bain circuit, whichever is available or suits to you, you need to set the ventilator keeping in mind the lung mechanics, okay, like resistance and compliance, the idea of which you would get during the manual mechanical ventilation while you are doing the ambu bagging, okay. So that is why you have to be keeping that thing also in mind. So right after intubating the trachea, you do a mechanical ventilation with the ambu bag, then you connect with the actual ventilator, right, the automatic ventilator. That will be the better thing, but you can adopt any other fashion or any other protocol if you have in your institution. Now this is the time to check the chest radiography pending and ABG and set the ventilator accordingly. Mode, which is usually volume control, assist control mode. Then you have to set a tidal volume of about 8 to 10 ml per kg, or even lower tidal volume if the lungs are edematous. Respiratory rate is kept between 16 to 20 per minute in ICU patients usually. FiO2, initial FiO2 will be 100%. The PEEP, that is positive end expiratory pressure, should be 5 centimeter of water. Then you have to set the trigger. So usually we select the flow trigger. If you are selecting a flow trigger, you should keep between 1 to 2 liter per minute initially, and then you can adjust later depending upon the patient ventilator synchronization. Then the usual I ratio should be 1:2. Lastly, set the alarm limits. Now, how to set the alarm appropriately will be discussed later. Final step is to start the ventilation, and post ventilation observe few things, few variables. After mechanical ventilation is initiated, see whether patient is receiving the set parameters, set variables. That's very important. And also check the blood pressure. About 25% of ICU patients may develop hypotension after tracheal intubation due to variety of reasons, most common of which are vasodilation due to use of sedatives which will respond to fluid administration. However, a vasopressor must be started along with fluid administration, as fluid bolus may take some time to achieve its effect on hemodynamics. So vasopressor should also be started early. Sometimes you may find that saturation falls down, and also the blood pressure. Dynamic hyperinflation or tension pneumothorax may also lead to similar problem. Therefore, it is better to switch to manual ventilation when you are in doubt, using an ambu bag or a bench circuit, and look for the chest rise, or even you should auscultate the chest. That will give you the sea of information about the lungs, airways. Sometimes ventilator may be malfunctioning, or sometimes your mechanical ventilation settings may be wrong. All you need to do is to perform the hand ventilation or manual ventilation and call the senior expert fellow immediately. I told you the standard settings which you will set on mechanical ventilation in a normal patient. However, in those with obstructed lung or in those with the stiff lungs, the settings on mechanical ventilation will be totally different. Okay, like pressure control or APRV mode may be better in stiff lungs. So we will discuss it more in the next few slides. Always check bilateral airway entry on auscultation, then start long-term sedation and paralysis SOS. Okay, you may have to insert the invasive lines for hemodynamic monitoring. Also, perform a chest X-ray. Look for tube position in chest X-ray, and also look for tension pneumothorax and all. Sometimes it may be possible after tracheal intubation and line insertion. And also do ABG, that is arterial blood gas, to see the gases like PO2, PCO2, pH and bicarbonate. That is very, very important. Always interpret your ABG when you are inspecting it bedside for a patient. And also remember to perform fast hug, BID. Okay, that is the mnemonic for general care of critically ill patients. Now let's talk about alarm settings. So alarm settings are also vital part of ventilator function. They provide the information about the patient's physiological condition and the status of machine's function. Idea is to ensure the safety of the ventilator patient interaction. The frequency of alarm buzz is actually high. A prospective observational study determined that each ventilator triggered an alarm cascade of up to 8 separate notifications once every 6 minutes. That is huge. Not all alarms generated by the mechanical ventilator provide actionable information, and that is the reason they must be set to appropriate settings, taking into considerations the patient's clinical conditions, which is often ignored while setting the alarm settings. So that's very important. So we set expired minute ventilation or minute volume between 10 to 20% above or below inspired minute volume. The value below it may be suggestive of leak in the circuit or ventilator. Low pressure alarm is set usually between 5 to 15 centimeter, below which you need to see ventilator disconnect or large leak. High peak pressure alarm is set usually between 40 to 45 centimeter, and higher peak pressure alarm or high peak pressure alarm is usually rung because of obstructed lung, or there is a resistance problem, tube problem, inspiratory valve issue, anything. Okay. Lower limit of tidal volume is usually set 20% below normal in pressure control ventilation. Low TV alarm means there is a stiff lung or maybe a leak. Another important alarm is the apnea or backup ventilation alarm, which should always be activated whenever you are putting the patient on pressure support mode or spontaneous mode. Apnea time is usually set 15 seconds. Okay. Apnea alarm means patient still not ready for weaning, and therefore you should change the mode back to controlled mode or whatever mode patient was on before putting to the spontaneous mode. Here is the video of alarm setting which we have to set in our ventilator usually. With any patient monitoring system or parameter, our general goal is to identify early warning signs that allow to reduce or prevent a patient harm. This goal is crucial during mechanical ventilation, as almost everything we do can cause patient harm, so you should be very careful. During volume control mode, peak pressure, plateau pressure are monitored. Okay, so these two variables you should always watch when the patient is on volume control mode. Whereas during the pressure control ventilation mode, expired tidal volume or expired minute volume should be monitored. So this is very important fundamental concept. There are various reasons for high peak pressure which are listed here, in which most common ones are related to high resistance of airways. Whenever there is a high inflow rate, okay, high inspiratory flow rate setting on the volume control mode, the pressure will be high, okay, the airway pressure will be high. Plateau pressure is displayed on ventilator monitoring whenever you put some inspiratory pause from 5 to 15% of total breath cycle. It should be kept below 25 to 30 centimeter to prevent a barotrauma or volutrauma. Mean airway pressure is the composite of all the pressures transmitted to the airway by the ventilator, which is basically calculated by the machine using area under airway pressure curve over the total ventilatory cycle. Higher mean airway pressure is good as it improves the oxygenation, but at the expense of lower cardiac output. So it will actually decrease the cardiac output and may decrease the blood pressure. So that is the reason we have to always monitor the blood pressure whenever patient is showing high mean arterial pressure. Keep your circulatory volume optimized in cases of higher mean airway pressure, and if it is causing the hypotension, decrease it for some time till hemodynamics is optimized. So how you can decrease the mean airway pressure? By obviously decreasing the volume or decreasing the pressure in volume control or pressure control modes respectively. In case of obstructed lung, it is vital to look at the flow time curve or flow time scalar, where expiratory flow should be observed carefully. If expiratory flow curve is not meeting the baseline, or if the expiration does not end completely, it results in air trapping, which gives rise to auto PEEP or intrinsic PEEP in the lung, and that contributes to hypotension sometimes and lot of other problems like ineffective triggering. That is the kind of patient ventilator asynchrony, so you should be careful about that and you have to treat it. So it should be monitored using expiratory hold maneuver. Okay, knowing the extent of intrinsic PEEP is very useful because sometimes it can cause increase in the work of breathing, and that is why you have to apply some external PEEP to nullify the effect of auto PEEP. Finally, I will conclude my lecture by by narrating three golden rules which have been taken from my beloved and respected professor Divatia sir from Tata Memorial Hospital, Mumbai, India. I should acknowledge. He says, never silence alarm unless problem is sorted out and chest is rising. If you are in doubt, better to take the control in your hands using ambu bag, and that is the reason we should have ambu bag behind each ICU beds. We have averted many airway and ventilation catastrophes in our ICU, and I have seen many in my last 10 years of critical care experience. So definitely you should keep ambu bag behind each ICU bed. So that's all for today. Thank you so much